Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, comment on this podcast, and find links and other information related to today's conversation. You'll also find our archives where you can listen to every episode we've ever done going back to 2006. Our email address is mail@econtalk.org. We'd love to hear from you. Today is January 28th, 2016. I want to thank listeners Sally Fama Cochran and Elizabeth Fama for recommending today's guest. He is Adam Cifu of the University of Chicago Medical School. He's won many awards for his teaching in the medical school. He's author of a book on clinical diagnosis. And today we're talking about his new book, co-authored with Vinay Prasad, Ending Medical Reversal, Improving Outcomes, Saving Lives. Adam, welcome to EconTalk.
Thank you very much.
I want to say first, this is a spectacular book that will resonate deeply with EconTalk listeners who are interested in health, in the question of what is reliable evidence, how do we know what we know, and ultimately I think we're going to get at the end of this conversation to issues related to economics and the parallels between health and evidence in health and economics, which we have talked about before. So I just want to start by encouraging people to check the book out. It's also delightfully written. I want to start with what is medical reversal, which is the subject of your book. What does that term mean, and how'd you coin it?
Medical reversal. So we actually had a lot of trouble coming up with what to call this. I like to start with thinking about how medicine is supposed to evolve, which I think of as replacement. We have a good therapy, a pill, a surgery, a device, whatever. We're happy with that. And then some good evidence comes out to tell us that something's better, and that something better replaces what we used to do, and we're sort of happy about that. And that's kind of how we expect medicine to improve bit by bit over time. Reversal is when a new therapy comes along that replaces the old therapy, but usually that new therapy is not based on, really foolproof evidence. But we only find that out after the new therapy's been adopted, used by hundreds, thousands, maybe millions of patients. And then we discover when more robust data comes out that, this new therapy is not as good as the old therapy. Maybe it's worse than the old therapy. Maybe it's worse than not doing anything at all. And that's where we consider medical reversal, where we've kind of flip-flopped on what we've recommended.
And the first question, of course, is is this a big problem or a small problem? We'd assume, given how phenomenal medical care is in its advances in technology and pharmaceuticals, that, this must happen, every once in a while, of course, but you seem to suggest it's a little more of a problem than one might think.
Yeah. To be completely honest, we don't know how much this happens. Vinay Prasad, my co-author, and I began thinking about this just when in our own clinical practice, we realized that some things we'd recommended a couple of years before, we not only no longer recommend, but we were sort of apologizing to our patients that we'd recommended it in the first place. And so we sought to figure out, is this just a rare occurrence that when it happens, it really, sticks in your head and certainly sticks in my patients' heads? Or is this something that's more frequent? A lot of people have looked into this, and in sort of various different interesting ways, which I can talk about. Our approach was actually just to look at one journal, really important journal, the New England Journal of Medicine, and we looked at all the articles published over a 10-year span. We got a lot of people to help us out with that since it was a pretty big job. And over those 10 years, we identified 146 articles about which concerned about 100 different therapies, which were clearly therapies that had been adopted, used widely, lots of money spent on them, that turned out to absolutely be the wrong thing. Our estimates, sort of taking other people's research with our research, is that maybe as much as 35-40% of what we do could be wrong.
It's a really big number.
It's a really big number.
One of the effects of your book is, and my listeners know how skeptical I am about lots of things, and one of the things I'm skeptical about is medical treatment and various new and old treatments. I'm always wondering, does this really work? Incredibly, even given how skeptical I am, this book actually made me even more skeptical, which is quite an achievement. things I'm doing now, of course, this is a good idea. I'm starting to think, well, I wonder if there's any evidence for this. And even if there is some evidence, is a good evidence. Let's start with some some prominent examples. And what's interesting about the book is the range of things that are not effective. It's not just, well, that pill didn't do what it's supposed to do. Talk about some of pick 3 or 4 that come to mind that didn't work, and talk about what happened, why they were reversed, the findings.
Sure. Well, maybe I'll start with, I think, where I started on this, and probably the thing that's most familiar to listeners is estrogen replacement therapy. Estrogen replacement therapy was really widely recommended for women after menopause and prescribed all throughout the late 80s, 90s, and even into the 2000s. And this was based on observational data, predominantly from the Nurses' Health Study, that showed us that women who used estrogen replacement therapy did better, had fewer cardiovascular events, heart attacks, strokes, things like that, than women who didn't use estrogen replacement therapy. This idea was made even more attractive because there was a good sort of biophysical, biochemical rationale of why we should use estrogen replacement therapy. We know that women develop coronary artery disease about 10 years later than men. We attribute that to the effect of estrogen. And so most doctors did this. I certainly recommended it to my patients. And then when a really good sort of experimental randomized controlled trial came out, we figured out that, estrogen replacement therapy really doesn't help reduce the risk of cardiovascular events. And for the first couple of years you use it, it may actually increase the rate of events. So that, for me, was the first time I began thinking about this. And I think I'll speak a little bit for my co-author, Dr. Prasad. I think the thing that got him the most, and certainly was shocking to me, was the story of using stents for stable coronary artery disease. Now, stents are these little expandable metal tubes, which are like magic. They can be inserted with a catheter into pretty much, at this point, any artery in the body, but speaking here about inserting them into coronary arteries, and therefore can effectively open up blockages of the coronary arteries. And we know for an absolute fact that those stents are life-saving in people who've had heart attacks, people who have what we call unstable angina, where they're sort of on the verge of having a heart attack. But what happened in the late 2000s is we started using these stents for people who had stable angina, people who were fine, but when they exercised, they would get chest pain because they had mild to moderate blockages in their heart, in their coronary arteries. It turned out that a ton of money was spent on this. By 2009, 80% of the Medicare dollars that were spent on coronary stents were spent on this indication, using them for stable coronary disease. And then this very famous trial, the Courage trial, came out in 2009, which showed that if you're looking at things like preventing heart attacks, preventing deaths, stents were no better than just the medical therapy we were using at the time. So I think those stick out in my mind as some of the most striking examples.
And you have a mix of things that were just ineffective, had no impact, and others that were perhaps ineffective, but in the case of the stent, you really don't want to put a stent in if it's not effective. It's the treatment itself often comes with risks of infection, side effects from a pill, et cetera, correct?
It's absolutely true. And so, some of the things that we state in the book, they probably didn't harm anybody. And the harm, probably was the cost of the procedure. In American medicine, nothing is cheap. There may be an opportunity cost for some of these interventions where the person got something that we thought was helping but wasn't, and maybe at the same time they could have been getting something which was actually effective. And then certainly another harm is, this really does affect people's faith in medicine. Whether you're a skeptic to begin with or not, once you've spent a year on a medication, which your doctor then tells you should come off because it's not doing anything, you're a little bit more, slow on the uptake for future recommendations, I think.
Just for a baseline, you talked about observational studies as being the original motivator for the estrogen replacement therapy. And this is a fantastic parallel in economics. So talk about what is the difference, because we're going to, I hope, talk about this more all throughout the conversation. What's an observational study on the one hand versus a randomized control trial or an RCT on the other? And why is one better than the other?
Yeah, great. So an observational study is really a natural experiment. And I think it's, in economics, probably, what you have to struggle with all the time. So that in medicine is when already something has differentiated two populations, two groups of people. It may be that one group has decided to take a medication while the other one hasn't. It may be that one group has been exposed to something, say, living in a poor neighborhood versus another group which has not been exposed to that. Or it may be that a doctor has made a decision to do an intervention on one group and decided not to do that intervention in the other group. And then an observational study will report the difference in outcomes for those two groups. Did the people who take the pill do better than the people who didn't take the pill? And it should be pretty obvious that, so what's wrong with that is that it's not just the pill that's different between those two groups of patients. Something motivated those people who took the pill to use it or their doctors to prescribe it, and something motivated the other people not to take the pill or not to prescribe it. And so usually in observational studies, when you look at the groups are very different. To go back to the estrogen replacement example, boy, when we look at that, women who took estrogen were younger, thinner, had actually better cholesterol levels. I think they actually drank a little bit more than the women who didn't. So it was a very different population. And so it was probably not the estrogen replacement therapy which was benefiting them, but everything else about them that made them have better outcomes.
So I'm going to play
what we call confounding.
Yeah, I'm going to play the believer for a minute, which is challenging for me because this is one of my big skepticisms in economics. Okay, so there's some confounding factors. You just ran off 4 or 5 of them. Control for those. That's what we have statistics for. That's what multivariate regression and other techniques do to control for those confounding factors. Then we can isolate the effect of the estrogen replacement.
So you're absolutely right, and these studies have a place, right? The problem is that we never know if we're completely adjusting for those confounding factors. And the people who did the Nurses' Health Study, man, they were smart. They were Harvard School of Public Health kind of people. And they controlled for, without the paper in front of me, I would say a dozen, probably more things. But these groups were so different that they weren't able to control for all the confounders. There was a wonderful study, and this is, using all medicine examples, from a couple of years back, where some really brilliant researchers took studies of a single intervention that were studied both in observational trials and in randomized controlled trials, which are really experiments, which get the whole confounding problem out of the picture. And it turned out that those studies agreed most of the time. I think about 80% is what I recall, which is good. But it's not perfect. And you don't know when those observational studies are steering you in the right direction and when they're steering you in the wrong direction.
And I guess I want to just hone in on this issue of you call mechanism or the underlying science, which, of course, we have an imperfect knowledge of also in both medicine and in economics. We have a pretty good idea, given what you mentioned in the data about differences between male and female heart attack rates, that estrogen in women probably protects them somewhat, perhaps. We don't know for sure because we don't really know how the heart exactly is affected by it. But it's presumed that that's the case. So then when you give people estrogen, that should reduce the probability of a heart attack. The problem was, of course, is that giving people estrogen may not be the same as producing estrogen. That's one problem. The other problem is you don't really understand the mechanism. But in a lot of these cases, it seems like the mechanism itself is the thing we don't really understand. And my question is, do we ever get at that underlying mechanism? If we did, we'd have a much better way of finding things to help.
Oh boy, that's so true. And I think if there's one thing I took away from the work that went into this book, it was the humility that was sort of forced upon me when I saw how many times we are absolutely sure that something will work because it should work. We understand the mechanism. We think we understand the biology. And boy, I mean, we know a ton about how the human body works. And then when everything lines up to say this intervention should work, and that's part of why it's been adopted, and then real empirical data shows that it doesn't work, it's shocking. And I think the fact is, God, the human body is just so complicated, and there are so many different things that impact on how a medication or a procedure works or doesn't work, that, I don't know. I mean, I hope we'll know it eventually, but right now we don't. And we need to go with, I guess, empiricism more than the biochemical rationale that underlies some of these decisions.
You talk about surrogate endpoints, and that's one of the challenges that this relates to. Explain what those are and why that's a challenge.
Sure. So, I think of the dichotomy as surrogate endpoints and clinical endpoints. And clinical endpoints are the things that you care about. It's how do I feel? Am I going to live longer? Am I going to avoid having a stroke? Like really, really key things. Surrogate endpoints are stand-ins for those. So it might be, how high is your blood pressure? How high is your cholesterol level? How high is your average sugar? Things that, you would have absolutely no idea about those numbers or those values unless you see a doctor. They don't bother you at all. And so when you come up with a new therapy, you really want it to improve a clinical endpoint. You want this new pill to decrease the number of heart attacks people have. But boy, to show that, you need a bunch of people, you need to follow them for a long time, and that's expensive. So it's a lot easier to pick a surrogate marker, a stand-in like blood pressure, and say, well, we've got this new pill and it lowers blood pressure, and that we know that people who have higher blood pressure are at higher risk for heart attacks. So it translates that lowering blood pressure should lower heart attacks, and we'll accept this therapy because we know it affects the surrogate marker in a good way.
So you mentioned one blood pressure medicine that in clinical trials did not have any clinical endpoint effect. It did affect, of course, the surrogate endpoint. It did lower blood pressure, but it didn't affect strokes, heart attack, et cetera. Is that true of all blood pressure medicine?
So that's not true of all blood pressure medications. I mean, most of the blood pressure medications we use, we do actually have hard endpoints on, and we've shown that they've decreased things like heart attack, strokes, even some of them overall mortality. But that's not true for all of them. The one that we discuss in the book is atenolol, which was marketed as tenormin for a long time. And I'm particularly attached to that because back in medical school we had to write this personal pharmacopoeia, which was 20 of our drugs we were most interested in and write all about them. And atenolol was the first drug in my personal pharmacopoeia.
Hard to let it go.
And it turned out, and it turned out that atenolol does do a really wonderful job at lowering blood pressure, as good as most of the other blood pressure medications we use today. But when you brought together all the studies in which it was compared to placebo, it turns out that doesn't improve mortality, doesn't improve the risk of heart attacks. It may slightly decrease the risk of strokes, but there are so many other medications which control the blood pressure just as well, but actually control all of those real clinical endpoints.
But to get back to this mechanism issue, we don't understand why it is that some medications that lower blood pressure seem to actually affect the things we care about, while this one did not. Absolutely true.
Absolutely true. I think there are certainly people who know a lot more than me about that, but nobody can really predict. Will this have the outcomes that we hope it does and expect it does?
So let's go back to randomized control trials. We talked about the challenge of the confounding factors in an observational study, a so-called natural experiment, a so-called statistical analysis of observable behavior and outcomes. Why is a randomized control trial better? What's better about it?
Yeah. So a randomized control trial is really an experiment. And so you take a group of people who you ask nicely to enroll in your study. You make sure the study is an ethical study approved by your institutional review board to say that there's equipoise. We don't know which is better. We don't know if the treatment is better than what we're presently doing. And then you randomize them, and half the group gets the treatment, half the group gets the placebo. And so those groups are exactly the same on average in all the risk factors that you know of, but also all the risk factors that you don't know of, but we might know of in 10 years. And so in a really well done randomized controlled trial, we know at the end that whatever difference there is in the group once the trial has ended is due to your intervention, whether it be a surgery or a pill or a device implant.
Well, you hope you know, because there are still issues about, as you say, you don't know everything to control for. It could be by chance that the people in the placebo group are different in ways that you don't observe. But the idea, of course, is the larger the sample, the more you hope you've dealt with that problem, because the law of large numbers, correct?
That is true. That is true. And I can tell by the way you talk, you are a true skeptic.
Yeah. But, what's fascinating is you actually came up, there are a lot of issues that come up in randomized controlled trials in economics that are problematic, mainly because there's a big difference between physiology and the setting that an experiment takes place in economics. It's going to be harder to generalize. There are issues, of course, in medical issues by population and geography, et cetera. But you did bring up a couple of really interesting challenges of randomized controlled trials that I had not thought of, one positive, one negative. I loved your point. A lot of people say, well, it's unethical to give people a placebo because they've got this condition and you're not helping them. So first, talk about, I think it's, if I got this correct, vertebroplasty. Talk about what the degree to which they tried to make the placebo as close as possible to the treatment, which I love that. And then talk about why it's actually kind of ethical. It is ethical. It's not what you think.
Yeah. Vertebroplasty is a wonderful example. So to take a step back at what vertebroplasty is, so people with osteoporosis, with thinning of the bones, most commonly postmenopausal women, who we seem to be picking on in today's conversation for some reason, will develop osteoporosis and then may develop what's called a spinal compression fracture. And if you picture the vertebrae in your back, a compression fracture is just when all of a sudden that collapses. Very common. The estimates are that there are 700,000 compression fractures in the United States every year, and about 280,000 of those are clinically important, meaning that people, develop back pain, go to the doctor with it. For years, our only real treatment for compression fractures was pain medication and time. And people do get better from these eventually. And then in the 80s, some radiologists came up with this kind of neat idea that, well, what if we take someone who has a compression fracture and we inject medical cement into that collapsed vertebrae? And so the vertebrae sort of puffs up, gets stabilized, the nerves that are coming around that area get a little bit more room to breathe, and people should get better. And this was an approved therapy based on some not perfect trials, which showed that people who got this procedure felt better than people who didn't get this procedure. The real test, though, was to design a study that had a placebo group as close to the intervention group as possible other than the vertebroplasty. And it was an amazing study done by some very brave researchers where patients were randomized either to have vertebroplasty or to get sham vertebroplasty. And the sham was that they took people to the procedure room. They prepped their back like they were going to do vertebroplasty. They actually opened the medical cement so the patient could smell the medical cement.
That's my favorite.
And then they just injected saline into their back. And it turned out that over the first month after the procedure, all the endpoints were exactly the same between the sham group and the intervention group. No difference in pain, no difference in quality of life, no difference in activity scores, nothing.
So that's fascinating, but I don't want people to hear about the opening of the cement because that's my favorite thing. But the other point is that, of course, sometimes the procedure harms you. So the placebo is great for the people who got that luck of the draw. It's
absolutely true, and the placebo group, in a way, is an insurance policy. And people argue that, is it ethical to do this sham procedure on people, to intervene on them in some way that has no chance of helping them. But in fact, in the vertebroplasty case, those people saved, thousands, maybe millions of people in the future from getting a procedure, which is not helpful.
And as you point out, though, sometimes it's actually harmful, and it's a blessing to get the placebo. You have a lot of interesting things to say about placebo effects. That's for another time. The other, before I get to the other part about RCTs, I want to ask you a more pointed question about reversal, which this is a good example of. I suspect there are people listening right now who are either patients or doctors who are either in line to receive this vertebroplasty or actually do one. Because one of the depressing aspects of this book is that a lot of these reverse procedures continue. So
yes, that is true. So
I don't know if that one's totally off. Everyone knows that's wrong. Nobody does it anymore. But there are plenty of things that you talk about in the book that continue. An example is you say in the book that rapid response teams don't work, don't show any effect. The idea of creating a mobile group of people inside a hospital to respond to crises and emergencies don't seem to have any impact. I mentioned that to a doctor friend of mine. Says, what? They don't? So either he missed the study or he doesn't agree with it. Surely some of these so-called reversals, people say, that's not a reversal. There's one study that found it didn't work. It's helped my patients. I know it.
Right. So I'll say in our defense, we were very careful in what we labeled reversals. And we only labeled something a reversal if the study that overturned the practice was clearly a better study than what had supported the practice in the past. Because you're absolutely right. I mean, are there things which clearly work, but then one study says they don't work? And yes, and we know from our statistics that that's going to happen. But so when we said something was a reversal, it's that the studies which had actually recommended this procedure or this intervention in the past were less robust than the ones which had overturned it. Rapid response teams are, I think, a great example. And I think right now we're not really sure if they're beneficial or not, but they have been adopted far and wide. The data that says they work are generally single-center studies. So one hospital shows that their rapid response teams work. Rapid response teams also, they make everybody feel better because there are more people around to come running and helping. And the idea that this would be beneficial, makes total sense. Person's having a problem, anybody can call the rapid response team. The fact is, though, that for a rapid response team to really clearly be shown to work, it needs to be shown to help patients. And you need to figure out what endpoint that is. Do you want your rapid response teams to save lives? Do you want your rapid response teams to get people out of the hospital faster? Or is your endpoint just that you want rapid response teams to send more people to the intensive care unit? And to this point, we haven't seen that rapid response teams save lives.
What are some of the psychological and monetary incentives that make it hard for doctors to admit that there is such a phenomenon for a therapy or practice they're involved in?
Yeah. This is always like the hardest thing for me to talk about, being, a 20 some odd years into my practice and being fully acculturated into medicine. I'd like to think, and I really do believe, that for the most part, when doctors are, shocked by reversals, maybe when actually they, argue against a practice that they've recommended being reversed, it's because they truly believe it works. They've not only invested a lot of time and energy into the practice, they've seen people who get, the intervention get better. And so they think it's the right thing to do for their patients. There is a part of it, though, that you can't deny that, if you've made a lot of money over the years during doing, a procedure on people's knees, which you believe it works, but it's also, helping you send your kids to college. when you find out that that doesn't work, you're probably a little bit more apt to argue with it.
Yeah, I don't have any problem giving that, making that argument. So, but it's a very common problem in economics as well. I like to argue that about half of the macroeconomists in America think they're in the top 5% of candidates to head the Federal Reserve, and that affects their willingness to criticize the Federal Reserve, even if they aren't aware of that subtle bias. But it's there. The other issue about randomized control trials I found so interesting is that in the medical area, sometimes an RCT will be stopped prematurely because the effect seems so dramatic. It would be cruel then to keep people on the placebo or on the treatment. And how does that affect the accuracy of the trials?
Yeah, this is another really nice piece of research by another group that. Well, I'll step back a little bit. I mean, clearly when a randomized controlled study is designed, we feel that it's basically an ethical necessity that if one treatment is coming out to be clearly superior than the other treatment, that trial needs to be stopped. Because if our new intervention is working really well, and we know it, boy, it's unethical to keep giving people the placebo, right? The issue is that, if you're doing a bunch of studies, your studies are always going to come up with somewhat different outcomes just through random chance. And so what we've found, looking at multiple studies over time, is that studies that are stopped early tend to overestimate the benefit of a treatment, which when you hear it, you say, yeah, thinking about that makes sense. It's surprising to me because I have to say my reaction is, when I'm listening to the radio in the morning and I hear about a new therapy and it's being released because the trial was stopped early because it was shown to be effective, I'm sort of more convinced by that. I'm like, wow, this must be really good if they had to stop the trial. But it turns out we probably should not look at it that way, and we should say, well, this may be one trial that was positive, but maybe there are other trials which will come out, which will be negative, and maybe this doesn't in fact work.
One of the problems you talk about, of course, is that even when we believe, and I think you're right, that randomized controlled trials are better than observational studies, they're very expensive.
Yes.
How do you deal with that reality? We want to make medicine better. How do we deal with the fact that the tool that we have to bring scientific technique to medicine, a true experiment, is really a problem?
Right. I think not only are they expensive, but you really need some very generous people to volunteer to be in the randomized control trial. I mean, it may not be cheaper for the individual, but it's a whole lot easier to just take the pill that your doctor gives you rather than enrolling in a trial where there's going to be a lot more follow-up, probably a lot more monitoring. And this is something that we struggle with. We know we need more of these trials, but how do you do it in a cheap, easy way? We threw out some examples. We are big fans of the nudge principle, and we thought the idea that for a lot of things, decisions which really we don't know which is best, which no patient would conceivably have some sort of predetermined reason to prefer one therapy to another, maybe that's something that you have to opt out to not be in the trial. So if you go to your doctor with sinusitis and she's deciding between two different medications, two different antibiotics, both of which we know works, we just don't know which is the most effective, and you have no reason to prefer ciprofloxacin to azithromycin, why not just have that person randomized unless they opt out, and we could get lots of data quickly in that way.
Do you think we're going to make some progress on these questions as we enter the so-called big data era? One of the things that you seem skeptical about is something we've talked about on the program before with Eric Topol, which is personalized medicine, the innovations that are coming in self-monitoring and other ways of assessing maybe effectiveness. You're a little more skeptical on that.
Right. I think that, personalized medicine and using people's genetics to tailor therapy to them has enormous promise. I think the issue, though, is that you still need to prove that therapies work. And there's even more temptation when you talk about personalized medicine to say, we know how this drug works on this gene, and so that should fix people. Well, you still don't know that until you've shown it. And in a way, personalized medicine may make randomized controlled trials and evidence-based medicine even more important, because we need to test each of these sort of personalized medicine interventions, on a smaller and smaller group of people, since our therapies will generalize to smaller and smaller groups, if that makes sense.
Yeah, sure. How do you deal with the criticism that your skepticism about so many received therapies and techniques is a recipe for, quote, doing nothing? I'm sure one of the things you hear, and I think you're right about this, and I get it all the time in economics, so I'm skeptical about people who say the minimum wage doesn't reduce employment. And I'm skeptical, I have to confess, because I think I understand the mechanism of how incentives work. Now, I might be wrong, but one of my responses then is that when people say, yeah, but look at the data, I want to say, well, then you've got to accept a different mechanism than mine, and that's going to have a lot of implications outside of just minimum wage policy. But anyway, when I say stuff like that, people say, oh, so we just do nothing? We've got these people who have terrible lives, they have terrible jobs, they have terrible opportunities in the labor force, and some people would say they're being exploited, and you just want to do nothing because you're not convinced it would help. Doctors are even in a worse position. There's a patient in pain, maybe under risk of death, and you're saying, well, we just don't know if it's going to work. And I'm sure many practitioners, and you are a practitioner, so you have to deal with this daily, would say, oh, so what am I supposed to do? Just go, I'll wait till the RCT comes out that shows me what to do? I've got to do something now.
That is so well put. I think the issue in medicine is that, one, you need to consider who you're treating, and two, you just need to be very open with the patient. So if you're talking about a healthy person and you're talking about a screening intervention or preventative therapy, I would say, boy, you need to be absolutely sure that's going to help them, because you're taking a perfectly healthy person and you're basically turning them into a patient and potentially making them sick with your intervention. When it's someone who's sick, who's in pain, well, then I think the bar is actually a little bit lower. And you think about what you have to offer. You think about the likelihood that it'll work, and it may be that it's based on observational studies. It may be that it's based on surrogate endpoints. And I think what's important is that you have an open discussion with the patient, and you say, look, this is what I have to offer you. Maybe I have a well-proven, older therapy and a less proven, newer therapy. And these are the reasons it might work. These are the reasons that it might not. This is why maybe I'm a little bit uncomfortable about it. And you let the patient make the decision. Just like doctors, we as patients actually have, I think, quite a breadth in our values. And I have some patients who, never want to take a medication unless it's been on the market for 10 years. I have other people who are, knocking on my door the day after something is advertised saying, I want that pill.
Yeah. And so you mentioned screening. We had Robert Aronowitz on the program talking about our urges to reduce our risk. And screening is very appealing, I think, to most of us. Catch it early. But like he appear to be somewhat skeptical.
Yeah. I mean, I think we are brought up with the ounce of prevention is worth a pound of cure, right?
Sure.
And there's nothing that makes more sense than screening. You find that breast cancer early, that prostate cancer early, it's got to help, right? The problem is, our tests are not perfect. The diseases out there are, even though we consider them common diseases, they're actually still rare. And so even with a pretty good test, when you're looking for a rare disease, you're going to come up with a lot of false positives. And those false positives cause anxiety among the patient. That's probably the least impactful. They also lead to procedures which probably don't need to be done, and often treatment which doesn't need to be done. Our recent data from the world of prostate cancer screening says that to save a life from prostate cancer, we actually need to treat about 30, 35 people for prostate cancer. That's a lot of people being treated just to save one life. And, if you're screening, you really need to take that into account.
But if it's my life that you're saving,
right.
I think, so
absolutely.
There's a statistical issue there of what's a statistical life versus, a personal experience. I think the question is,
right.
But in that case, I'm being not facetious. I'm being, I don't know what the right word is, but the real question is, for me, it's 1 out of 36 with lots of unpleasant side effects until I know otherwise, right? We don't know who the one is. We're not saying it's too expensive to save the one. You're saying we don't know who the one is, and that's not a great return.
Absolutely, and you're right. I mean, it's 1 in 3 for erectile dysfunction, or 1 in 3 for incontinence after that intervention. So you're very likely to have the side effects. You're less likely to have the benefit. But that's where I think patient decision making has to really enter into it. And I feel like as long as people are well informed and you're letting them know what the data is, and there really is some chance of benefit, a reasonable chance of benefit that it's reasonable to suggest, well then, people probably should have the freedom to make those decisions.
I mean, one of the lessons of the book for me, and we'll talk about at the end, is that educating oneself as a patient or as a potential patient is really important. And I think most Americans, maybe most people generally, we like deferring to some authority. We like not in other areas, but in medicine, it's like, look, doctor, you're the expert. I trust you. You carry yourself so well. One of the things that struck me about your book is, you're really emphasizing, as I do, the importance of humility in my field, and you're emphasizing the importance of humility in your field. A lot of people we don't want a humble doctor. I want an arrogant one. I want a doctor who can just say, this is going to work. I've done this thousands of times. There's no side of blah, blah, blah. So there is a interesting culture there that you're encouraging a change in.
Right. And I would say, you need to find the doctor that you need, right? I certainly take care of people who are like that, who want me to be the decider, right? To be very clear about what I think is the right thing to do, and they will follow my advice. I have other people who, want to have an open discussion, maybe an open argument about just about every decision. And you need to find a doctor who'll do it the way you want to do it. Obviously, if you're someone who wants to argue and you have a doctor who wants to dictate, you're probably not going to be a very good pair.
Yeah, for sure. Many economists, not all, but many economists really dislike the FDA, the Food and Drug Administration. This goes back to work by Sam Peltzman, who argued that the FDA kills people. It's so careful in making sure that drugs are safe, it rules out drugs and therapies that could save lives, and they raise the cost through their tests and their demands, which makes it harder to get any one drug to market. You argue for the other direction. You suggest that the FDA should be more vigilant, not so much in safety, but in efficacy. So defend that position.
Yeah. My co-author, Vinay Prasad, he has said to me, and I really take this as truth, is that, the people who work at the FDA, those people are the most underappreciated group of people in the world, and do an incredible job. Because on the one hand, they're being yelled at by people who are saying, you are slowing down progress. You are holding up drugs that could save lives. You are responsible for, mortality and morbidity. And on the other hand, there are people like us who are saying, wait, you should make sure that this absolutely works before you approve it and let people be exposed to this. So it's a difficult place to work, and it's a difficult sort of road to hoe. I think what I would say is that we want to make sure that the FDA is assuring that we have data that treatments work eventually. There will be cases that a therapy looks really good in terms of its ability to affect surrogate endpoints, say. And it's a drug that's really necessary because maybe the treatments for the disease we have out there aren't so good. It's probably completely reasonable that the FDA lets that drug out there and lets that start being used. But it really seems necessary that there should be studies ongoing at the time that the FDA approves that drug that will show us those real endpoints, those clinical endpoints that matter. What often happens is that these drugs are approved based on surrogate endpoints, and then we never get that final data, and we're left with, using therapies that might work, but we're not sure they do. And that seems like the wrong way to proceed.
So let me make another analogy between medicine and economics I hadn't thought of until this conversation, which is, so in the case of the financial sector, we say, well, we don't want any banks to go broke because that can lead to chaos and disaster and people lose their money and they really don't like losing their money. So what we're going to do is we're going to insure banks' deposits so that you won't be at that risk. Of course, we understand that changes the incentives facing banks, that they're going to then tend to want to be riskier because they'll still be able to attract investors and depositors because their money's insured. So then we have to then, of course, keep an eye on the banks and have rules about what they can invest in and what their safety is and whether they're approved or not by a ratings agency. And of course, eventually there's a unpleasant symbiotic relationship between the ratings agency and the banks, and they tend to work together, not as independently as they're supposed to, and banks start investing in things that are actually quite risky but look not so risky, and the ratings agencies go along because that's how they make their money, et cetera, et cetera. So in the medical area, we've got this lovely thing on the surface, which is third-party payment, either through health insurance or government subsidies and programs of various kinds, Medicare, Medicaid. So people don't pay for their medicine. So my interest in finding out whether this thing works or not is very small. If it doesn't work, that's life. Negative side effects, well, I don't want that. So we have the FDA. What they mainly worry about is whether there's negative side effects. Unfortunately, that means there's a natural incentive, and I think economists underestimate this part of the FDA-industry relationship, to keep the industry somewhat happy, right? Unfortunately, it's true that the high costs of FDA approval mean that drugs take a long time to get approved, and that means that a lot of drugs that might have been invested in aren't worth it anymore. But at the same time, it kind of creates a cartel for the pharmaceutical industry. So they don't have a lot of competition because there's this huge cost of approving a new drug. And they kind of like that. The first part, the delay, the cost, they don't like. The semi-cartel monopoly thing, that's really great. So to me, the FDA, of course, the people involved in it day to day have a hard job. They're good-hearted people. But the influences they're under must be subtle and in a way that I feel that the Federal Reserve governors are under. They're coming into contact with people every day that are not necessarily what the American people want to be doing. I don't know. It seems like unpleasant.
I think that's an amazing analogy. And I mean, two subtle things I would add to it also is that, because of the cost of developing these drugs, there's a very subtle incentive that if companies feel like they're going to be held to what they feel might be unreasonable standards, the incentive to spend this money and develop these drugs go down. The other thing, which I thought as you were talking about the banks, the physicians really rely on the FDA because the FDA is in a way our insurance company. The FDA takes the heat when a drug doesn't work or causes harm, not the physicians. Yeah. So the FDA is getting, both pressure and possibly influence in multiple directions.
And you talk about that very thoughtfully in your book about, in fact, let's turn to that. This isn't the FDA per se, but it's about these subtle influences that we all operate under. And just to close the economics financial thing for the moment, I think the real key here is that our medical system, the way it is structured through government programs and tax deductibility of healthcare payments mostly, it just changes the feedback loops that would normally be there. And it does that between patients and doctors, and it does that in the investment world also. And I'll leave it at that.
Yes, but absolutely.
Talk about thought leaders and what you call super specialists, because I thought that was extremely interesting about those incentives that face those folks.
Yeah. I think about this in a way that, when we talk about the amount of medicine that can be wrong, those are to some extent, made up numbers, and they certainly don't affect any one doctor. You may be seeing, I don't know, a generalist who's practicing from a very clear evidence base because the diseases that doctor takes care of are common things which are treated by, which have been studied very well. When you start to get sick and see a more and more specialized physicians, maybe for the problem you have, the therapies that they recommend may be less well studied, and that's because they affect fewer people, and because you're so in need that you're probably more willing to accept therapies that are not as well studied. The other thing is that very often those specialists in medicine today, and it's one of the reasons why, American medicine is terrific, that we have people who study such, minute areas of medicine that they begin to just understand everything that's known about that. And it makes them more willing, I think, to adopt therapies based on what they know because they're experts and they feel like it's foolproof. Adding to that, those people are often most involved in the studies. They're most involved with the companies that are developing drugs and devices. And so those are people who, are probably the people you want to see with some of the problems, but maybe ones whose therapies might be most prone to reversal.
Talk about their roles, consultants and influencers.
Yeah. So it's interesting. So, many of those people, it's hard to generalize on this.
Of course, they're all fine people that would never, ever have any psychological influence. Okay, put that aside. Go ahead.
Right. So clearly to become an expert in your field in today's world where so much of our drug and therapy trials are funded by industry because the NIH can't fund anything, can't fund everything, and they're certainly not going to be developing every new drug. Very often, these super specialists have some sort of affiliation with industry. They may be consultants on trials. They may actually be running the trials that are funded by drug companies, or they may believe strongly in a new medication that works and end up being a spokesperson for these medications, either paid or not. And you can imagine, hearing all those possibilities that probably gets harder and harder to be completely unbiased in your recommendations and your thoughts about these if you begin to have a financial stake in the medications.
So say, just hypothetically, somebody who maybe worked for Goldman Sachs and goes and works for the government knowing they're going to go back to Goldman Sachs. I'm sure it doesn't have any effect because they only care about the public interest.
Absolutely. And that's a completely hypothetical example.
Yeah. Well, unfortunately, there's more than one. So we're not talking about any one person. So it's not really that damaging. I can use Citibank, too, if we need to. Anyway, let's move on. Now, one of the book is full of interesting analysis of the current state of this problem of medical reversal. But toward the end of the book, you speculate about how we might create a different system of medical education that would change things, and medical research, the way it's structured. Sketch out just a little of that. We don't have time for the full thing. I encourage people to read the book. But what's the biggest changes you would make to medical education if you were a czar? And what are the odds anybody's going to listen? Sorry about that last
there are a lot of things standing in the way of this. But our idea, and it's an idea which Dr. Prasad, my co-author, actually published first. But it's certainly been in the thought for a long time. Is that because we think so much reversal is based on we think something should work, and so we're going to adopt it before we know that it actually does work. And one of the reasons that is because that's how medical education is structured. We learn the biochemistry, the physiology, the pathophysiology as the very first things in medical school. And over the first 2 years, we kind of get convinced that everything works mechanistically the way we think it does. And it's only in the later years that when we're introduced to patients and actually making patient care decisions that the more of the sort of empiricism comes into play here. And so our idea is that, could we flip that around? Could doctors be trained in really evidence-based medicine at the beginning? And be presented with patients and cases, and then be asked to research, what is the best treatment here? Why is that the best treatment? What's the evidence base behind that? And then certainly it's crucial that doctors understand pathophysiology. It's crucial not only for taking care of patients, but it's crucial for moving the field forward, because you can't come up with good research questions without that knowledge. But maybe that should come later. And so you'd be seeing that sort of science through the window of what you've already learned about taking care of patients. Changing medical education is difficult. We've been teaching medicine, with some tweaks pretty similar to the way we were doing it 100 years ago. But I think there are more and more people who are realizing the flaws in what we do that, I'm hopeful there'll be changes.
And one of the issues we've talked a lot about lately here at EconTalk is, I would call, evidence-based economics, which, who could be against it? The challenge, of course, is good evidence and bad evidence. That's always the problem. And I think about the analog of flipping the practice in economic education. I'm not sure I want people. You should look at data and you should look at how the world works. The question is, how do you do that in a way that doesn't lead to overconfidence in other problems? And it's very hard. The data, and people say, well, let the data speak for themselves, but the data often don't speak for themselves. Well, I'd say they never do. You really have to have some kind of theory in the background. Do you agree with that?
Yes, I do. And it's been one of the most interesting things that I've experienced, talking about this book and the research that went into the book, is that there are some things that, I've thought a lot about the article, and I've been trained for 20 years in how to think about these articles, that I really, truly think it says one thing, and someone who I'm talking to really, truly thinks it says something different. And when we get down to it and we discuss it, it's often easy to figure out why we're looking at it from a different viewpoint. But these are sort of honest arguments, and usually I think both of us end up being right. And so, although evidence-based medicine and probably evidence-based economics is the way to go, you still have to have people thinking about this beyond the evidence and agreeing about what the evidence means.
Yeah, for sure. How has the book and the research that you've done to write it, how has it affected your clinical practice? Does it weigh on you day to day? Do you feel it? Is it different than it was 2 years ago, 5 years ago, when you were with a patient and dealing with a problem?
I think it has. I mean, as you can imagine, talking to me, I wouldn't say I'm a nihilist, but I'm a bit of a skeptic, and I'm generally a less is more type practitioner. And what I think it's done is it's made me, on the one hand, very aware of that, so I think hard about whether the treatments I'm recommending are truly beneficial to the patient. Interestingly, in the other direction, it's made me realize what my bias is very clearly, and it's made me careful about applying that bias to my patients who may have a very different bias. So I admit to them freely, listen, this is my value system. This is how I recommend things. And I need to hear what yours are so I can change my thinking in a way to meet what you want. And it's been educational in a way that I think I would not have expected before beginning this effort.
Yeah, I assumed it's created some mindfulness maybe about yourself that maybe wasn't there before. It's really, really interesting. Yeah. When I'm a big fan of empowering consumers and patients, and I'm not a big fan of the nanny state and lots of other, especially regulation that's supposed to help people that actually doesn't, or even worse, was designed to help somebody else but was packaged as a way of helping consumers, twisted through some political process. But when I talk about that, especially in medical areas, people say, well, people just aren't smart enough to make their own decisions. They need doctors to tell them what to do. And I'm curious, I'd like to hear let's close with this, your advice. You write about it quite eloquently in the book, but for those who don't have the book yet, what should we do as patients, given the reality that the world and the body is a complicated place? How should this affect this knowledge of medical reversal? How do we deal with it in the moment when we've got challenges, and how can we educate patients to be better at dealing with that?
Yeah, that is a struggle. The one big struggle, and what I really encourage people to do, is to just feel comfortable asking questions when you see your doctor. I take care of lots of people who I know from outside my office, and I can't tell you how many people who are incredibly smart, brave people who never shy away from anything in the rest of their lives come into the office and all of a sudden, kind of clam up and don't ask the questions they should be asking. And I think that's a little bit that they feel like, this is medicine. I don't know anything about this. There's a little bit of that, sort of power differential of someone sitting on one side of the table in a white coat and someone on the other side just, in their street clothes.
Or a paper gown.
Right, or a paper gown, which is torn in the back, certainly. Yeah. And so it's important to arm yourself with the real questions, and those real questions are, to begin with, are not, what are the side effects of this medication? Will my insurance pay for this medication? It's, does this medication work? How do you know it works? How likely is it to benefit me if you give it to me? What are the other options to the care plan that you're outlining here? And then maybe even ask the doctor to, argue the other side of the coin for a second so you can sort of figure out what you need to do. We as doctors, we're certainly trained to be open to these discussions. This entire generation of doctors practicing now has been brought up with the idea that patient autonomy is key and the paternalism of the past, is gone. But, we don't always practice what we learn. And I find that when we're really taught to practice what we've learned, it's when we don't know what to do. So, whenever there's something like, we talked about prostate cancer screening or mammograms between 40 and 50, the guidelines are, well, we should definitely discuss this with your patient. Because those are the places that we really don't know what to recommend. So we put it on the patient to make the impossible decision.
But isn't the challenge in that situation sometimes that you're visiting the wielder of a hammer and you've got a nail, or you don't have the nail, and they're going to use the hammer. They're going to say, you need this procedure. I think one of the biggest challenges we face, and I don't think, as you point out in the book, it's not malicious, it's not sinister, but so often specialists, they've come to believe their therapy or surgery works when in fact maybe it doesn't work so well. And in that situation, I think it's a very difficult challenge for the patient.
Yes. I'm a general internist, I'm a generalist, and I think that's why those people are key to help you find the right person. Because it is true, the specialists who, we rely on every day, really do look at things through, the glasses of a hepatologist or a cardiologist, and that's what they think about, which is really necessary if you need those people, but maybe not for everything. The other problem is that, as a patient, you can always find someone who will look at your health care in the way that you do. So if you want something done and the first two doctors you see say it's not the right thing to do, you can always find someone who will. So you need to find a doctor you trust, who you think really has your best interest at heart, and is going to steer you to the right people when they can't care for you, which is honestly frequently.
My guest today has been Adam Cifu. His name is spelled with a C, as in Charlie, at the beginning. I know many of you are listening in your car or commuting in some way and don't have access necessarily to the internet. You might want to Google Dr. Cifu, but it's Cifu is how you spell his last name. His book is Ending Medical Reversal. Adam, thanks for being part of EconTalk.
Thank you very much for having me. It's been really wonderful.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.